Good morning. My name is Anahita Jalilvand. I'm a general surgery resident at the Ohio State Wexner Medical Center. I'd like to thank SAGES and the moderators for the opportunity to present this research on low visceral adipose tissue regulatory T cells are associated with higher comorbidity severity in patients undergoing bariatric surgery. We have no disclosures. Visceral adipose tissue inflammation has been linked to the development of insulin resistance and atherosclerosis in murine models of obesity. We also know that downregulation of specific anti-inflammatory VAT regulatory T cells, or Tregs, are key to the pathogenesis of the downstream effects of obesity. We have also preliminarily shown that VAT Treg abundance is inversely correlated to increasing BMI when comparing lean in patients with obesity. Additionally, metabolic syndrome is typically characterized by a constellation of obesity-related complications, usually including central adiposity, dyslipidemia, hypertension, and insulin resistance. There is some literature to suggest that chronic low-grade inflammation may be implicated in the development of metabolic syndrome, but its ultimate pathophysiology remains unclear. We hypothesized that within patients with obesity, decreased VAT Treg abundance would be associated with increased prevalence and severity of preoperative comorbidities such as type 2 diabetes, hypertension, and hyperlipidemia. Therefore, the objectives of this study were to determine the association between VAT Treg abundance and, firstly, the prevalence of obesity-related comorbidities in bariatric candidates preoperatively, and two, the comorbidity severity, which we defined as the medication usage for each one of these comorbidities. And this was in an attempt to preliminarily start teasing out the pathophysiology of metabolic syndrome in bariatric patients. To do this, we prospectively enrolled 78 patients who were undergoing bariatric surgery to get visceral adipose tissue harvest at the time of their surgery. We excluded patients who had baseline chronic inflammatory diseases, prior cancer history or organ transplantation, end-stage liver or kidney disease, or who were smoking, as these would be confounders in their inflammatory profile. The adipose tissue was harvested and digested immediately following surgery in order to obtain the stromal-vascular fraction, which includes all the immune cells. These immune cells were then characterized by flow cytometry, specifically looking for regulatory T cells with the markers shown here. We then divided patients by whether or not they had a low or high VAT Treg abundance, and we defined this by our median VAT Treg abundance for our cohort, which was 3%. So patients in the low VAT Treg cohort had less than 3% Treg abundance in their visceral adipose tissue, and those in the high Treg abundance cohort had greater than 3%. We then compared these groups in terms of baseline demographics, preoperative prevalence of type 2 diabetes, hypertension, hyperlipidemia. Within patients with diabetes, we also looked at specific glycemic parameters, including plasma insulin, glucose, and metrics for insulin resistance, which we used HOMA-IR. And then within patients with hypertension, we looked at the number of medications listed preoperatively. And then finally, for hyperlipidemic patients, we looked at the use of statin. In terms of our baseline characteristics, compared to patients with high visceral adipose tissue weight or operative excess body weight, meaning baseline excess weight at the time of their intake evaluation and operative excess body weight at the time of their operation. Furthermore, when we looked at the overall cohort, we saw no difference in the prevalence of type 2 diabetes overall preoperatively when comparing these two groups, but there was a significant difference in the severity of diabetes. So patients in the low VAT Treg cohort were significantly more likely to be insulin dependent compared to the high VAT Treg cohort, whereas the high VAT Treg cohort were more likely to be controlled on oral hypoglycemics. Within diabetic patients, those with low VAT Treg Tregs were significantly more likely to have a higher plasma insulin level at the time of surgery. And they also trended towards having a higher intake hemoglobin A1C and operative hemoglobin A1C, and they also trended towards a higher metric of insulin resistance as measured by HOMA-IR. When we looked at the association overall between VAT Tregs and hypertension and hyperlipidemia, we again found no significant difference between the prevalence of hypertension and hyperlipidemia between these two cohorts. However, there was a trend in the use of patients requiring 2 or more antihypertensive medications in the low VAT Treg cohort, 44 versus 25%. When we looked overall, when we looked at patients who had a hypertension on the left, you can see that within those who had a diagnosis of hypertension, patients in the low VAT Treg cohort were significantly more likely to require 2 or more antihypertensive medications, whereas those who had a preoperative diagnosis of hyperlipidemia similarly were significantly more likely to require medication or a statin preoperatively compared to those with a high VAT Tregs. So in putting this all together, we found that lower VAT Treg abundance was not associated in our cohort with excess body weight or the overall prevalence of type 2 diabetes, hypertension, and hyperlipidemia. However, it was associated within diabetics with a trend towards higher insulin dependence and worse preoperative glycemic parameters. It also, within hypertensive patients, was associated with the use of multiple antihypertensive agents and the use of statins for hyperlipidemic patients. They're also suggested that the patients with low VAT Treg abundance might have 1 or more of these comorbidities. Our study is limited by the variability of human data, although we do have a fairly large sample size for the data that we accumulated. Inflammation is modulated by a number of factors, and there are a number of confounders. And so getting clean data on inflammation for human subjects is often difficult and not as easy as it is for murine models. Our cutoff for Treg abundance was determined primarily by our own sample size, or by our own sample, and this might not be clinically relevant, but there's no data currently out there to suggest what a clinically relevant Treg abundance is, and so we did this based on our cohort. Future studies will have to look at this. We also only selectively looked at Tregs, and future studies will look at the interaction between Tregs and other inflammatory cells in the adipose tissue, as well as important adipokines and inflammatory markers. In conclusion, despite our limitations, I think this data preliminarily showed that decreasing VAT Treg abundance may play an important role in mediating systemic complications of obesity and metabolic syndrome in patients with obesity. And it also importantly brings up a possibility of modulating the adipose tissue inflammation to improve metabolic health for these patients, and ultimately may help to improve medication responsiveness if we're seeing that patients who have decreased adipose tissue inflammation actually require less medications and potentially have less severe versions of those comorbidities. I'll take any questions at this time. And I'd like to thank again SAGES for the opportunity to present our research.